Every single day in the pathology lab, I see hundreds of liver function test results flag as abnormal, and every day people panic over them. But here is the secret that most patients and even some healthcare professionals get wrong. The standard liver function panel that includes ALT, AST, GGT and ALP doesn't actually measure how well your liver is functioning. It's measuring something else entirely. In this video, I'm going to break down exactly what each of these markers really measures, the biochemical clues they leave behind, and how we read the whole panel as one connected story. By the end, you will be able to look at your own lab report and actually understand it. Let's get into it. But first, we need to bust a massive myth. The standard liver function test panel doesn't measure capacity. What it mostly measures is liver cell injury by quantifying enzymes that leak out of liver cells when they are stressed, inflamed, or dying. Think of these enzymes less like a fuel gauge and more like a smoke detector. They don't tell you exactly what's on fire, but they tell you something is happening and roughly where to look. Because these enzymes live inside liver cells at concentrations thousands of times higher than in the blood, even relatively minor cell membrane damage is enough to leak meaningful amounts into the circulation. That's exactly why these tests are so incredibly sensitive. Now, just a side note, true liver function, its ability to synthesize proteins, clear ammonia, or produce clotting factors is reflected by a different set of markers like albumin, total protein, and prothrombin or INR, which deserve their own dedicated video. To understand how these smoke detectors work, let's start with the two you will see most often on your report, ALT and AST. ALT stands for alanine aminotransferase, floating freely in the main cellular fluid called the cytoplasm. When liver cells are damaged from a virus, fat buildup, or medications, they leak ALT into the bloodstream. Because ALT is so liver specific, it's considered the most reliable marker for pointing directly at the liver problem. Normal ALT is roughly 7 to 55 units per liter for adult men and 7 to 45 units per liter for adult women. AST is ALT's cousin. However, it's far less liver specific. AST is also found in the heart, skeletal muscles, kidneys, red blood cells, and the brain. So a high AST on its own could be your liver, or it could just be that you did an intense leg day at the gym yesterday. They also differ in how long they persist in the bloodstream. ALT has a longer biological half-life of roughly 47 hours, while AST clears faster, in about 17 hours. Practically, this means that after a single brief liver insult, AST will fall back toward normal noticeably faster than ALT on repeat testing. But here is where it gets incredibly useful clinically. We don't just look at ALT and AST in isolation. We look at the mathematical relationship between them. Specifically, we divide AST by ALT. In the lab, this AST to ALT ratio is known as the Ritis ratio, and it's one of the most powerful diagnostic clues. The order of the math here is critical. If you calculate it backward as ALT to AST, the numbers will mean completely different things and cause unnecessary panic. So it's always AST divided by ALT. To understand how this ratio matters, you need to know exactly where these enzymes live inside the cell. Unlike ALT, which floats in the cytoplasm, a huge percentage of AST is locked deep inside the cell's powerhouse, the mitochondria. In most common mild liver conditions, like acute viral hepatitis or early fatty liver disease, minor cell stress easily leaks ALT. So ALT sits higher than AST, and the AST to ALT ratio is less than 1. But there are two major clinical situations where this pattern flips and AST climbs higher than ALT. The first is alcohol-related liver disease. Here, the AST to ALT ratio frequently pushes above 2. This happens because alcohol acts as a direct toxin to those mitochondria, cracking them open and spilling that trapped AST. Simultaneously, alcohol depletes vitamin B6, which is a crucial building block the liver needs to manufacture ALT. So AST flattens out while ALT production crashes. It's a distinct biochemical fingerprint. The second scenario is advanced fibrosis and cirrhosis. This is a massive clinical pearl. If a patient has had fatty liver disease for years with normal AST to ALT ratio of less than 1 and suddenly their AST creeps higher than their ALT, doctors pay close attention. As the liver gets progressively scarred, blood flow changes. The liver struggles to clear AST from circulation and deeper mitochondrial damage accumulates. An AST to ALT ratio climbing above 1 in chronic liver disease is a major red flag that the patient is progressing towards cirrhosis. While ALT and AST tell us about damage to the liver cells themselves, our next marker tells us about the liver's drainage network, the biliary tree. Alkaline phosphatase, or ALP, is critical for aiding lipid transport and bone mineralization. It comes from several different tissues, mostly the liver, the bile ducts, and bones, with the smaller contributions from the intestines and placenta. In growing kids and teenagers, ALP is naturally 2 to 3 times the adult upper limit purely from healthy bone growth. In adults, when ALP rises sharply, particularly more than 3 to 4 times the upper limit, it's often pointing toward a blocked bile duct. Think of a gallstone obstructing the main drainage pathway. But here is a crucial difference in how the lab works. Unlike ALT and AST, which just passively leak out of damaged cells, ALP rises during a blockage because of a process called upregulated synthesis. When bile fluid backs up, the increased pressure and bile acids actually trigger the cells lining your drainage network to physically manufacture and release excessive amounts of ALP. It's an active cellular reaction to the structural blockage. But because ALP is also found in bone, how do we know if a high result means your liver's drainage network is blocked or if you just have a bone issue? For labs that want to pin the source down definitively, they can run an ALP isoenzyme electrophoresis. This is a specialized laboratory technique that physically separates the bone-specific, liver-specific, and intestinal fractions based on their electrical charge. However, in routine clinical practice, we have a much faster approach to solving this mystery. We look at our next marker, GGT. Gamma-glutamyl transferase, or GGT, is the single most sensitive enzyme indicator of liver disease we have. To understand why it is so incredibly responsive, you have to look at where it lives and what it actually does. Biochemically, GGT is anchored to the outer surface of cell membranes, predominantly on the cells lining the liver's biliary drainage network. Its main day job is moving amino acids across the cell membrane, but its most critical function is recycling glutathione, the body's master antioxidant. When the liver is exposed to toxins or metabolic stress, it desperately needs to defend itself, so it ramps up GGT activity to build more antioxidants. This location and function gives GGT a particular superpower. It solves the ALP mystery instantly. If your ALP is high and your GGT is also high, the problem is almost certainly coming from your liver or its drainage network. However, if your ALP is high but your GGT is normal, the ALP is probably coming from your bones. This single pairing of GGT and ALP results saves patients from unnecessary follow-up imaging. Because of its role in handling toxic stress, GGT is heavily induced by certain substances. Alcohol, as well as medications like phenytoin and rifampicin, forces the liver to ramp up its enzyme production machinery to clear the load, causing an isolated GGT rise. But plenty of non-drinkers have elevated GGT too, especially with obesity or fatty liver disease, which also cause chronic metabolic stress in the liver. So a high GGT is a prompt to look further, not an immediate verdict on someone's drinking habits. So we've covered the injury enzymes and the drainage enzymes. Finally, we have bilirubin. This marker reflects how well your liver is actually processing a waste product, and it's the molecule behind the yellow tint of jaundice. To understand a bilirubin result, you just need to know the basics of its life cycle. Bilirubin is a dark yellow waste product created when old red blood cells break down. It arrives at the liver in a fat-soluble form called unconjugated bilirubin. The liver's job is to chemically modify it into a water-soluble form called conjugated bilirubin, so it can be safely pumped into the drainage network and exit the body through the gut. For reading and understanding your lab report, this distinction is diagnostically vital. A rise heavily dominated by unconjugated bilirubin usually points to a problem before the liver's drainage system, such as excess red blood cells breaking down or a mild glitch in the liver's processing machinery. But a rise dominated by conjugated bilirubin points to an export failure. The liver did its job, but a roadblock in the drainage network is preventing it from leaving. Because that dark pigment is not reaching your intestines, your stool turns a pale clay color. Meanwhile, all that backed up conjugated bilirubin spills backward into your bloodstream, where it gets filtered out by your kidneys, turning your urine the color of dark tea. Now, there is a lot more to this story. You might be looking at your own lab report right now, noticing a mildly elevated unconjugated bilirubin, which is often a completely harmless genetic quirk called Gilbert syndrome. Because bilirubin biochemistry, genetic variations, and the entirely separate topic of neonatal jaundice, where newborn babies turn yellow shortly after birth, are so complex, they actually require their own dedicated deep dive. I will be making a separate video in the future breaking down physiological versus pathological jaundice, so make sure you're subscribed so you don't miss that one. So how does this all come together? Well, lab scientists and doctors don't read these numbers one at a time. We read the pattern. If ALT and AST are climbing the most, that's a hepatocellular pattern, which indicates liver cell damage. If ALP and GGT are climbing, that's a cholestatic pattern, an obstructed drainage network. And right now, the single most common reason for a mildly abnormal hepatocellular pattern is not alcohol, and it's not hepatitis. It's a silent condition officially called MASLD, metabolic dysfunction associated steatotic liver disease. You probably know it by its old name, fatty liver disease. It now affects roughly 1 in 3 adults worldwide, and it can sit quietly for years, causing only a mild ALT elevation before anyone investigates it properly. Because MASLD affects so many people, and because it's highly reversible if caught early, I have made a complete deep dive video entirely on it. I cover exactly how fat damages the cells, the new medications, and how to reverse it. I will link that video on the screen at the end of this one and down in the description. So if a mild ALT elevation is usually because of MASLD, when should a liver panel actually worry you? Generally, you look for 3 things. The elevation is massive, usually more than 15 to 20 times the upper limit of normal. When it spikes into the thousands, we are actually looking at acute viral hepatitis, drug-induced injury, or ischemic shock liver. Second, it's persistent across repeat tests. And third, it's paired with actual symptoms like fatigue, abdominal pain, or jaundice. Also, never overlook medications. Paracetamol in excessive doses is the single most common cause of acute liver failure in several Western countries. Certain antibiotics, statins, and anti-seizure medications can also cause abnormal results that usually reverse once the drug is stopped. So just a quick recap. ALT and AST reflect liver cell injury. The AST to ALT ratio is a massive clue for alcohol damage or advancing cirrhosis. ALP points to the drainage network, GGT is the sensitive tiebreaker, and bilirubin reflects how well your liver is clearing waste. A single, mildly elevated ALT on an otherwise normal panel is incredibly common. It's a prompt to look closer, not a reason to panic. If you want to understand the #1 cause of elevated liver enzymes today, click the video on the screen right now to watch my full breakdown on MASLT. Hit subscribe if you found this useful, and I'll see you in the next one.